My name is Anthony. I'm a British and US trained endoscopy consultant and neurologist with extensive experience in hearing and balance disorders. In previous clips, I have described how you can use the Eplead maneuver or the Summit maneuver to manage patients who present with benign proximal positional vertigo. This, as you probably know, will deal with those who present with problems relating to the posterior semicircular canal, which is the most common form of benign paroxysmal positional vertigo, BPPV. However, BPPV can affect other semicircular canals. The lateral semicircular canal can be affected in up to 30% of cases, and even in rare cases, you have the superior canal being affected. I like to describe the management of patients who present with horizontal canal lithosis or lateral canal lithosis, as well as a brief mention on the rare superior canal lithosis or lithosis. In terms of diagnosis, I will demonstrate the supine row maneuver, which is used to diagnose a patient with lateral or horizontal canal lithosis. The important thing is noting the nystagmus that they have, whether it is downward pointing, changing nystagmus, in which case it's termed a geotrophic nystagmus, or if it's an upward pointing nystagmus, which case is termed an apogeotropic nystagmus. In other words, it's going anti-gravity direction, and it's generally on a horizontal plane, so it's a straight nystagmus rather than the torsional nystagmus you see with either posterior semicircular canal or superior canal involvement. Also, you want to bring the head up to 30 degrees so that you bring the canals into plane. And I'll demonstrate briefly. I'll be using myself as a model. I'll hate to be the cause of someone else developing a canal lithosis or lithosis as also the maneuver that I did to demonstrate to others. But here we go. You have your patient lying down flat. The couch has been raised up to 30 degrees. I generally prefer people taking off their glasses to reduce fixation. And then I'll ask them lie down. And you ask them from a supine position to turn their head quickly to one side, like that, to 45 degrees, and note the direction of the nystagmus. Once it passes after 6 seconds, go to the other side and go quickly, and note the direction of the nystagmus. If the patient has a geotrophic nystagmus, or they have an apogeotropic nystagmus, that's significant in terms of the nature of the canal involvement they have, either a cupulolithosis or a canalolithosis. The side with the strongest response is the affected side, because you could actually have the same response on both sides, and this may well be confusing, but note, if you go accordance with Oswald's second law, the side that gives you the most aggressive response is the affected side. Also, make a note of the duration of the nystagmus. Canalolithosis tend to be less than 60 seconds in response with some degree of latency, whereas the cupulolithosis may have a shorter latency, but with cupulolithosis you have more than 60 seconds being the response. Make a note of those who have anterior part of the horizontal canal being involved in canalolithosis, and they usually have a nystagmus which goes upwards, as an apogeotropic nystagmus, but they're usually short-lived. But the management for both the anterior crus canalolithosis of the horizontal canal as well as the horizontal canal cupulolithosis are the same. An alternative test for horizontal canal BPPV is the head pitch test or the bow and lead test. In this test, the patient is seated. The examiner then bends the patient's head by 30 degrees and assesses for nystagmus. Usually the nystagmus disappears because the horizontal canal is in the true horizontal position. The examiner then bends the head forwards to 60 degrees and assesses for nystagmus. a fast-paced nystagmus may be present. If this goes towards the affected side, then this would suggest the patient has a canalolithiasis. If the nystagmus is towards the unaffected ear, then this would suggest a cupulolithiasis. Then the patient is returned back to a neutral position and see if the patient is dizzy or has nystagmus. Now, in general terms, you could treat a patient with a horizontal canal BPPV by adopting the forced prolonged positioning maneuver, in which case you ask the patient to lie with the affected ear upwards. In other words, if this is the affected side, patient sleeps lying on the opposite side, and they stay there for about 12 hours. And that's a very legitimate way of looking after them. But should this fail, you could always adopt one of the maneuvers. I'll first of all go through the Lampert roll and the variation for cupulolithiasis, which is the Trigrelis modification. Then I'll describe the Goffoni for both canalolithiasis and cupulolithiasis affecting this side. And then I'll briefly talk about Iacoviно's procedure for anterior canal lithiasis or superior canal lithiasis, especially when the side cannot be determined. Now, first, I'll describe Lampert's barbecue roll technique for taking care of patients with a canal lithiasis affecting the horizontal canal. Having made your diagnosis, you now get your patients to lie supine. And I will flatten the couch because it needs to be flat. I'll take off the glasses. So, ask them to lie down supine. Like so. This is the affected side. So you want the patient to turn anti-clockwise for right side all the way around to a total of 270 degrees and then sit them up. So assuming I'm here in this neutral position and assuming this is the side that's affected, I'm going to turn in the opposite direction first 45 degrees, 90 degrees, and I'll stay about 60 seconds in that 90-degree position. I'll turn around and stay there for 60 seconds. I turn around, I'll stay there for 6 seconds before sitting up. If the patient has a cupulolithiasis, you can adopt the Trigrelis modification, whereby you turn the head first to the affected side before you now go all the way around and turn it the opposite direction. So assuming this is side affected, I will end up turning the opposite direction in an anti-clockwise fashion, having gone first to the affected side. I'll demonstrate. So this is the supine neutral position. Assuming this is the side that's affected, you get the patient to turn to that side first, or you do it yourself. And after 6 seconds, bring them back up, turn them round all the way to the side, and keep them there for 60 seconds. And turn them flat on their tummies, keep them for 60 seconds. And turn them right, having completed 360 degrees, and you set them up. Those would conclude the maneuvers described by Lampert and Turelli for horizontal canal lithosis and horizontal cupule lithosis, respectively. Alternatively, you could use Goffoni's medication used to manage patients with horizontal canal lithosis. Now, with Goffoni's procedure, you ask patients to sit in a neutral position, and assuming this is the affected side, you want the patient to lie on the normal side. I'll demonstrate. From this position, you turn the patient downwards like that, in a neutral position. And once they settle down, either nystagmus passes or the dizziness passes, or about 60 seconds, you now turn the head so they're facing downwards towards the normal side. And keep them there for 60 seconds, then sit them up. They may experience a reversal of the nystagmus. Just hold them in place so they don't panic. The reversal of the nystagmus is a good sign that the particles are being entered into the usual, so don't be alarmed. If, however, they have a cupulolithosis affecting this side that I've marked here, you do the opposite. You get them to lie on the affected side before you turn the head upwards. And I'll demonstrate. So they're seated, you turn them flat on the side, keep them there for 60 seconds before you now turn them to turn upwards. After 60 seconds, you sit them up. And watch out for the reversal of the nystagmus or the unsteadiness so the patient doesn't fall. So you can adopt any of those techniques to treat first for canal lithosis or alternative cupulolithosis. The last maneuver can be used for the variant of the canal lithosis, in which the anterior arm of the horizontal canal is involved. And hopefully this should help your patients with horizontal canal lithosis or horizontal canal cupulolithosis. In patients that have involvement of the anterior canal, or the superior canal, you could use Iacoviно's procedure to assess and manage these cases. And I'll demonstrate. So you have the patient seated, and you want the patient to be brought back on this position, get them down into a head hanging position, flex the neck, and then sit them up. There is a forced prolonged position maneuver you could try for patients with recalcitrant superior canal lithosis or involvement, which involves you doing the test to confirm, getting them to a head hanging position, then rapidly bring them forward and keep their head flexed, but they need to be kept in position for 24 hours. This would obviously require hospital admission. For patients that do not respond well to maneuvers, other therapies have been found to be useful. One such would be to control any blood pressure abnormality or any underlying diabetic related illness. Some authors have found administering vitamin D or indeed giving tympanic steroids helpful. You may want to consider other potential differential diagnoses such as Meniere's disease, vesicular neuronitis or labyrinthitis, migraines. You want to look at posterior fossa tumors, perilymphatic fistulas, trauma, superior canal dehiscence syndrome, infections, migraines, epilepsy, multiple sclerosis, potential autoimmune inner ear disease. In a situation where an underlying cause has not been established and the
symptoms do not resolve with any of the conservative maneuvers or indeed with supplements, surgical intervention may be required, as highlighted in the slide. My particular preference would be to occlude the offending canal. However,
that requires a hospital admission and they're very rare. I hope you found all these helpful. And if you do have any concerns, I'll be more than happy to discuss it with you. Bear in mind, these maneuvers should be done by healthcare professionals who are experienced with air and balance disorders, typically your endoscopic surgeon, your doctor or general practitioner with an interest in balance disorders, some audiologists, audiology physicians, and balance therapists with interest in balance.